youngest parts are the oldest, meaning they held the wisdom. So like I'm 46, so my 6-year-old self is 40 years old. If that math doesn't make sense to you, it's because it's emotional math. It's inverse math in the sense that your 6-year-old has been in the car for the last 40 years.
Yeah.
So when I start talking to the 6-year-old as if they are, equals and or like, I want to learn from you. I understand that you've been here longer. If they're behaving like they are 6 or like have those 6-year-old needs and stuff like that, then we want to structure the system as somewhat like, where's the today you, where's the future you, how can we kind of create that? And so when we're talking temporal space and time, we have to help people be able to create past, present, and future then, because a lot of themselves don't know what's going on and who's what and where.
It's what waits underneath the mask, beneath the bruises you stop looking at.
All right. Welcome to the Taproot Therapy Collective podcast. I'm here with Adam O'Brien of the Wounded Healer Institute, and I am so glad to finally connect. I've sat down to write this email starting 2 years ago when I started hearing about your work from people and genuinely meant to. And every time I would start to touch the keyboard, my life would blow up and the building would be up for sale and we would be trying to buy it, or meteors would fall out of the skies. So luckily I'm not a behaviorist, and it didn't Pavlovianly condition me to stop trying to connect with Adam, and I'm really glad that we finally are connecting. So thank you so much for being here, and I'm wondering if you can kind of introduce some of the work that you're doing and the tensions that you're diagnosing in the industry that are a lot of the same tensions that we talk about on here.
Yeah, great. Yeah, thank you for having me and extending the invite. And the backdrop there is pretty heartwarming in a lot of ways. Definitely interested to kind of branch out into kind of what you're doing. As far as what I'm doing, so the Wounded Healers Institute kind of came as an idea of, if not everybody is diagnosable, then like what are people doing for their mental health? Like what are they doing for their physical health? And a lot of my kind of dynamic of like, so one of my private practices is called mutual arising, and it's a Taoist concept, but has a familiar kind of context within Buddhism of dependent origination. And when I look at dependent origination and that dependence word and that addiction and like kind of both sides of the coin type of thing, I was trying to, understand the world as it's like mirror opposite. So what would be the mirror opposite of like a mental health gym? So like, can we have like a middle ground of, mental health where we can have these conversations, and where does the line of pathology? So my dissertation and my academic research really led me to try and understand that like there's a dynamic between trauma, dissociation, and addiction that really seems to be missing. And when I look at the system as a whole, like we kind of put drug addiction over there, and the DSMs are finding evidence that there's like process addictions, and there's like eating disorder, and there's different ways of framing all of this stuff, but I've never been satisfied with the definition. And then around 2012 they started coming out with definitions that addiction is a treatable disease. And I'm not against the disease model. I do, as like kind of empirically kind of want to know what we mean by those words. As a qualitative thinker, I kind of want to know the meaning and how and whys. And my it's kind of led me to a point where I kind of want to have a general conversation with more people. I think there's some universals there. My research highlights that addiction is transdiagnostic. We just identified that, in 2022, I cited an article that the dissociation was just identified as transdiagnostic. And so I'm making the argument that we do have some things that we're missing as far as diagnoses within the addiction framework, and how it relates to this transdiagnostic, world, and what's underneath all of this, and not just the surface level answers of how are you feeling, but like what's really kind of going on with you, and that transition from trauma informed care to now I think dissociation, it really is trauma, meaning that everything that we look at, to me, as far as the symptoms of PTSD are basically describing dissociation.
So there's a whole lot there. I'll give
Sure.
you a couple jumping off points and see what's interesting to you here. I mean, one of the things I think is that the overlap between dissociation and addiction is something that I think some of the best people treating addiction now are starting to notice independently. So when a lot of people that are highly effective at doing something start noticing it at the same time, that's something that I think the industry should pay attention to and maybe treat as a sort of pre-research indicator, objective type metric of what works.
Pre-research, we're going to say qualitative versus quantitative.
Yeah.
You know, and that to me highlighted in my work between right brain, left brain processes, and who would label what. If you're a doctor, you're labeling what you're seeing and you're naming the symptoms. Same thing with like PTSD. You're just basically reiterating what the client has said, and you're finding that there's like themes here. But if we're going to say that like pre-research, because I think it's dangerous, especially with, you know, I'm a person in long-term recovery, I think it's dangerous for us to say that quantitative versus qualitative research, that there is a hierarchy here. I really see that we are separate and equal, not separate but equal. And qualitatively, like if somebody had done a qualitative test as far as psychologically, like, and I know that like sociology and marketing and PR type of stuff, but if we were to be honest in hindsight, I'm imagining that now in hindsight, every person who was working in the addiction field is like, yeah, a non-addictive opiate, how can you even do that? Like, that's an oxymoron.
Yeah.
Like, who was safeguarding that kind of ad or that type of qualitative, like, you know, and maybe they had the quantitative or whatever that means to them, but like there's something about the qualitative narrative that we should just kind of have our, like, you know, our BS button to be like, because those who have qualitative lived experience, you know, isn't pre-research, right? We have to give that more value to me than it being like this kind of like exploring things and then kind of getting down to a nitty gritty. Like, they're both valuable. One is just more supported and or, you know, validity and being what that is, it's more kind of supported and or believed. And I think we're now entering in a very interesting age, particularly with like the James Webb Telescope and the whole stuff with you know, the origins and the Big Bang and like, you know, what came before chicken or the egg type of thing. We're still in that conversation, and like some of the realities that are coming through, seems that the spiritual solutions and or answers and a lot of the great thinkers that we've had are coming, you know, to the same conclusion that, like, you know, this is, you know, the proverbial, you know, God experience, and there is no separation between the observer and the observed.
Yeah. I mean, I a lot there. I mean, one of the things that I totally agree with you on is that the qualitative and quantitative research, you know, one, are both kind of like, you know, equal and should be more supported. But then two, like, I don't know that there's a huge distinction between those like we try and make. Like, a ton of people will talk about qualitative research, and it's like if a researcher if a clinician notices in the room that they try 15 things and one of those things gets 80 people well and the other one is not as effective, and then they write a qualitative study, is that completely qualitative? Because it starts off, I mean, yeah, you do a randomized controlled trial to check for biases, not to create empiricism, you know?
Well, true, but I think, you know, when we kind of get into to me, the dynamics and the philosophicals of my work, particularly, like this removing implicit bias sounds a lot to me like removing disease.
Yep.
And I'm very cautious of that because of our work as a trauma, you know, and, you know, knowing what you do as well. Like, the implicit system is where we're really talking about, because any complicated issues that are presenting later in life usually have happened before the age of 3. And these are it's our implicit system. Our implicit system is our right brain. It is our feelings. We've been listening to somebody else label us for too long in that sense. So I do this little thought experiment of like, is what is irrational? What if that is a rational brain's way of labeling emotional?
Well, I think that's why some of the Jungian in-depth guys talk about the truth of metaphor, is you've got a part of the brain that doesn't think in language, but it still thinks in meaning. And one of the ways that greater meaning has to be filtered into language where it can't quite fit is through symbol. It's through metaphor. It's through emotional cosmology, you know.
Right, and the symbols of language and who's using it though. So that's where we start to get into the dissociative effect of like us as clinicians being able to kind of know who is talking dependent upon the language in which they are framing it or the age, developmental age that it is being presented. This is how we're able to see. And once you see dissociation as a phenomena of a happening, you can't unsee it.
Yeah.
And you start to see it in everything. And that is whatever that effect is called or whatever. But like, it is one of those powerful things that really tell us that we're onto something here. And I am willing to legally say that, like, I can know if people are all there or not in that sense. You know what I mean? If they're acting as if they are all there, and, the nuance of doubting and or needing empirical evidence, like the evidence is that like we are here or that emotions are real, but like if you can't feel them, that doesn't mean they don't exist.
Exactly. And a lot of the therapy that I'm very skeptical of, like misappropriations of CBT, definitely, ABA therapy, where you're not really taking into account the child's experience, you're just taking into account other people's experience. Right. I feel like what they're doing is turning off emotion by making someone dissociate so that is easier for the system or easier for the family. And just because you've made this, kind of objective metric that you're trying to treat or the symptom as you create it come down, that doesn't mean that the person's not screaming inside, which is still a problem for me as a clinician, Well,
skilled dissociation, right? Are we just teaching that? But we do have to play around a little bit with like the dissociative effects. So what my research, kind of highlighted is that there is like a normative range, has been not necessarily my work has highlighted this, but like people who have dissociative, experiences and or phenomena as like, parts of self, they experience, they can still experience the normal range of dissociation, like, driving a car and kind of getting lost in that. But I mean, they're fully capable. So I'll kind of do a little bit of my spiel with you because, respectful of the answers that you give, that like, they're not necessarily meant to be tricks, but they are kind of fun. And how I've come to understand, and I think like the mainstay that I would want somebody to walk away with and like think about for a while. I mean, anything that I kind of say, I hope that, but like this one is the one that's profound to me, is that the physical body is the psychological unconscious. And they can't be separated other than through idea and or separation. So there is an ultimate reality that we are all like here. We're all together. We're all like one in some type of microcosm of like the space between things is not absence.
Yeah.
Right. The rational brain as like 1 + 1 = 2. When we start to get into the CBT, like 1 + 1 = 2, like only shit. It's a matter of like, okay, well, how about if I prove to you that 1 + 1 = 3 beyond a reasonable doubt? If I could prove to you that beyond a reasonable doubt in the real world, 1 + 1 = 3, would you take a leap of faith that like maybe there are other answers out there? So the 1 + 1, and even 1 × 1 would equal 3.
Yeah.
Like we have to start to define the words that we mean by that and the lived experience of them. So
could you give an example that is a little bit more concrete of that for the clinical psychology students that have just taken their first research 101 class that are going to email me and say that I shouldn't have a license right after this episode airs? Just go ahead and speak directly to them because they're there. They're listening.
Okay. So, you mean, do you think I have to give them the answer?
No, just make that concept a little bit more concrete.
Well,
this is more just because I think it would be funny than
So as far as the answer, I mean, as far as the dissociative kind of spectrum is kind of what I was looking at. So when we look at the spectrum of it, we find pathology and we find, a normative range. So if the norms are kind of labeling the pathology, then what would the pathology label the norm, kind of a thing? And I think a lot of artists and a lot of people have done that enough that like we can kind of see kind of what their opinion of like the normative, is. And if we're going to be normal as like, okay, so 1 + 1 = 2, there, like that's the reality that we live in. You know, that's when things add up. And usually when people say things aren't adding up, they say that it's irrational or there's something wrong with that answer, right? They start to like be pretty like, you know, rigid in their like thinking, like this is what I was taught. And this is the difference between, you know, trained versus educated and or lived experience versus, you know, I know the answer to the question. And like, and I, you know, with clients, some clients are like, you know, pretty, you know, like 1 + 1 = 2. There's no other answer, dude. Like you, in the real world, like, yes, I'm putting these qualifiers in there to kind of boost it up. But you know, the answer will rather annoy those who are stuck. And I want to be sensitive to like the conversation that we're opening. And I feel like this is the reason why I'm doing it, is because if we're going to talk about psychedelics and if we're going to talk about dissociation, if people think that dissociation is the absence of mind, it is the presence of body.
Yeah.
And
it's the
body
experience of
unconscious.
another part of the brain, another part of the network that we normally are not consciously engaging with.
And the unconscious is the body. And as the body takes over, because the mind is off, we're talking about the default mode network.
Yeah.
We're talking about a shifting of a gear into another state that a person who has or has not experienced it, you know, a person who hasn't doesn't know what it is and feel like there's something going wrong. The part that would label that 1 + 1 only = 2 would hear this answer and be like, uh-oh. And it's pretty simple of an answer. And it's mother, father, baby. It's about what process are you involved? Are these numbers involved in? Past, present, and future. 1 + 1 = 3. There's a you know, and I'm sure the philosophical kind of underpinnings of qualitative versus quantitative. If you are able to hear that, you were in like it was rigid, you're probably in your left brain, and that 1 + 1 can only = 2. Well, that's what you were taught and trained, but like also the real world is this. So people who live in the real world with dissociation are highly adaptable. And this is where like dissociation is not the absence of. And so when we define the unconscious as having a consciousness, and it is your lived experience, then your lived experience starts to be much more valuable than the words that other people use. And I also have started to look at like dissociation and learning disorder, because they have, you know, piped in. Maya Salalovitz has a book called The Unbroken Brain about, and her kind of presentation on, you know, addiction being a learning disorder, because you keep doing the same thing over and over again, expecting different results. It's just like, no, there's a reenactment here of relief that I am reenacting that I need, because the dissociative system is overloaded by either past trauma that hasn't been able to resolve naturally or through means, or, you know, through, you know, just living with it and toughing it out. And like, that gets heavy, you know? So when I was looking at the systems, and I think this will be valuable in this conversation, that like, when we start looking at the biology of it, the body is really innocent in the sense that like, it is going to believe what it is that you are telling it until it has some other like, you know, and it's going to give, and that like, oh, checked out. No, that, don't believe it. And now, whether or not that's, you know, related to like kind of, you know, certain themes, but like if we are able to be in a neutral state, we can receive the positives and negatives. And this is a meditative type of thing too. We can just kind of witness the thoughts and the feelings and the positive and the negatives, and just let them be for a little bit. That neutral is so important to be able to have. And dissociation as a process isn't neutral. It is the first responder on the scene.
Yeah.
It is numbing you so the cannabinoid system can come and start helping you heal. So when I say that people are addicted to trauma, which Van der Kolk was the first to, you know, relatively say that in the literature, 1985, he was talking about the dependence of people being the opioid system in the body. The opioid system in the body, and the naltrexone, as a lot of clinicians are learning, is that naltrexone is like a transdiagnostic feature, because it's being used for eating disorder, bariatric surgeries. It's being used for dissociative disorders, alcohol cravings, obviously for the opioid, you know, means to it. I mean, anything. We have a clear understanding of the addictive processes with, you know, spending and buying and, you know, stuff like that. But like, when the start of the healing process is the opiate and somebody else labels that as the problem.
Mm-hmm.
Well, the dissociative effect starts taking you into a land where time doesn't matter. You're in the amygdala.
Yeah.
People who have complex PTSD usually have, that kind of, and I would say the other side of the coin is that some people are so rigid in their, numbers, and some people are so fluid in their numbers. There isn't that hybrid kind of experience back and forth. Now, a little bit about me, in my journey, and, my lived experience was I had an accident, a pretty simple accident when I was about 3. And this has always been my reality. And I had a good enough life, a bunch of developmental. I have skin issues and like pain problems from from my birth and stuff like that. But the out of body experience that I remember and its connection to the dissociative system, of which dissociation in the opiate version versus dissociation into like the psychedelic version, where we have the pineal gland versus the opioid and cannabinoid system, right? We're talking about like biological. I'm not calling anybody an addict, but like they would behave like an addict if like their drug opiates weren't like getting their hit.
Yeah.
So like we go to like the TV or the drama, and like people get caught in these news cycles. I mean, I think most people are now kind of getting away from and seeking their own kind of like teacher rather than like news source.
Yeah.
They want a framing of something that makes sense to them. And when I start looking at how dissociation and how people could be addicted to trauma or addicted to anything other than a drug or gambling, because those are the only 2 real legal ones we have. And I'm not buying that. And my bachelor's is in history, and I look at like, how long have we known that absolute power corrupts absolutely? So is that not addiction?
Well, I mean, one of the things that I've written about a little bit that it seems like you're hitting on is that things like dissociation, things like synesthesia, things like addiction are way more normal than we pretend they are. We just don't say that they're a symptom until they're all the way up here.
They become problematic. When they're problematic for those in charge, they start to label it.
Yeah.
And the person who is experiencing, I mean, a lot of times that, I'm sure you have like those experiences where people start to, they label that like something else is happening to them that they can't explain. And then they go to a medical, and like whether or not they can, translate it. I mean, I would really like to help the medical model, get I would want the medical model to be able to get unconscious informed consent.
Well, that's the problem with dissociation is like, are you familiar with Brainspotting that David Grand does, or emotional transformation therapy that Dr. Stephen Vasquez does? With the
more familiar with David Grand. I'm an approved consultant in Brainspotting.
Okay.
And a trainer, yeah.
So one of the things that I use ETT and Brainspotting together, Brainspotting, if no one's familiar, which you probably haven't listened to many of this episodes of the show if you're not familiar, but it's a position therapy that I find to be a lot more effective for more people than EMDR is, and then also a lot more controlled in how you process. And then emotional transformation therapy uses the several devices, but it's basically light, color, flicker rates, very specific hues of color, and then direction of light against the pupil, and you can process a little slower, but a little bit more surgically than Brainspotting. And I use both of them together with dissociation, especially. But one of the things that I try and tell people for one of my issues with like the classic cognitive behavioral treatment plan is like, I'm telling people when your dissociation comes down, your goals are about to change. Like you're telling me that you're fine with your reality, that your partner is abusive to you or emotionally abusive to you, or that your environment isn't safe, but you're cool with that, and that you've been in recovery, but you had a problem with alcohol, whatever. When I bring dissociation down, you're going to start to feel your emotional experience in a way where those things will become a much more present problem. And it's like trying to explain to a fish what's outside of water. Like they can't conceive of that yet. And I'm trying to say, I want you to feel this. I want you to kind of say that I've done this with multiple people, and like, just take my word for it. Once your ability to dissociate comes down, you're going to be working on regulating the amount of emotion that you're going to start to feel. Do you see that in Brainspotting, or does that make sense?
It makes sense. So a little kind of background, I think is helpful because we can compare and contrast, not necessarily against each other's, us, but like our different things that we do. So I also do progressive counting, which was developed by Dr. Ricky Greenwald, who was my EMDR trainer originally, and then deep brain reorienting with who validated or kind of confirmed, Brainspotting, Frank Corrigan, and psychedelics. So the question that like I have played with is that like when you are like decreasing somebody's dissociation, you're basically saying that you are putting them into their body because their body is rejecting them because there is pain.
Absolutely.
On some level, right? So, but
you can't, when you said unconscious consent, that's why I started talking about that, because you can't make a treatment plan for a pain that you are not feeling, even if I know that it's there,
Right. That's if the opioid system is at play as the primary dissociative feature. And if you have somebody who's like sick, like, whether it's dope sick or like, that's a good example of somebody who's kind of, they're in their kind of like opiate, kind of like uncomfortable, grumpy stage. But if people are in their like kind of dissociated, like imaginative world, and it kind of comes down to me for like, theta, alpha, and, theta, beta, and alpha ratios, because I also do neurofeedback and putting people in
community brain mapping there too.
Yeah.
So that was huge, being able to see when I did therapy what changed in the brain before neuromodulation started. That was really wild. Theta is incredibly important.
So like the dissociative effect, if the body is kicking out the mind, it's a matter of what percentage is the mind and what percentage is the body. Because the body may be turning off the systems, and that's why the body being the unconscious is so important to me, because it does help us be able to define who is giving what permission, right? And
Absolutely.
who has an opinion, who has a lived experience. And I did a panel with Vander Kolk and his wife Lucia Sky, and we were talking about like the body being the differential system, meaning that it's like ones and zeros, and like it can give you answers if you know how to talk to it. Unconscious informed consent is having your body be agreeable to something, but people's wirings can be crossed. So my near-death experience really crossed my wires because I thought that numb was calm.
Yeah.
And my labeling system would have been all backwards comparative to like everybody else's. And I had to learn that kind of in my own way. I also had my skin condition. I basically will itch until I bleed. And that actually felt good. So like then my wires get crossed again in that sense.
Yeah.
So uncrossing our wires, healing, and all that process, what system is activating. And I think, somewhat we have to be kind of cautious of like, sometimes people have imaginative stuff, and the biggest thing that I love to kind of think about is this reenactment. Like, why does history repeat? And like, how can we talk to it? How can we get it to stop? Like, what is it that we need to do, whether that's individual or personally or like societally, and that when we can talk to the unconscious, I think it's kind of like if the unconscious is accessible and communicative, then people are going to get a lot out of their work. And I see that with my more dissociative clients. They have much more access to be honest with themselves and much more capacity than those who have it shut off. And
it's fascinating because what they do is a lot of times like they tend to have like lower self-esteem or second guess themselves, or they've plugged into life. And a lot of them are very successful and smart, but they don't really trust their own sense of self in the community or in the environment. But when it comes down to like the core parts of identity that you want to reconnect most people to, it's like they'll go to the map for those and they never forgot those things because they're spending so much time in the brainstem. They're spending so much time in theta wave that those more emotional truths that you have to teach other patients that are less dissociative to recognize, they are not ever good. They don't have the luxury of pretending those things aren't real,
right? But I don't know. That's what I don't know. Who is dissociated? Because I had to live. I was trapped in my body, in my brainstem. Like at 3, there was a part of me that was stuck there in a sense, and there was a part that went on. And so like I can tap into that 3-year-old and have those biological processes understood. I can have a kind of like communicative yes or no type of conversation. Like how much of our language is nonverbal?
Yeah.
So like really teaching people, what that is, and, not necessarily kind of going down the parts rabbit hole, but like those facets of self. So my other math equation is like the youngest part of you is the oldest one.
Mm-hmm.
And that's the wisdom that therapy has been seeking, that people could like find within themselves, is that like you've been through this before.
Yeah.
You've been here before. And
Well,
what
how
did you
many
do?
people do, like, I read all of these biographies of people that I think are in touch with that. A lot of them are dead and, very old. Some of them are still around. And then you also talk to therapists a lot about, or I talk to therapists a lot about reconnecting people to something. And everybody seems to describe the breakthrough that is kind of healing in midlife, or the thing that lets them kind of put things back together, as this remembering of something that was forgotten in so many different languages,
Right.
But that's what all of them are saying, is that I was born knowing this, or I knew this before I was born, and I forgot that, and now I'm reconnected to it. But,
Right.
you can't.
We hear the same thing in psychedelics.
That makes the empiricists so mad. The objective researchers so mad, because they're like, what is this woo-woo thing? How can I randomize control trial that? And it's like, you can, in that everyone tends to say this when they get better, and you can listen to that language, but you can't necessarily put it in a randomized control trial study that is completely quantifiable,
Right. And that's the limitations of it. I don't mind that exists, but I don't feel that, like, because you don't have the answers, that doesn't mean that mine is, not valid.
I would say that it exists whether or not you mind, like,
well, it's a matter
yeah.
of who
Yeah.
has that preference. I want to know who has that preference within your psyche. And if we start talking about, and this is where, like some of the bigger ramifications, I think even legally though, but like, I mean, psychology, if it takes psychology, whatever, 8 to 12 times to diagnose dissociative disorders, and
shouldn't take that long.
and we have to kind of question where we rank our educational system. I think we have to question who is in charge to be able to, feed us lines like follow the science, but then don't allow us to.
But Adam,
the science is pretty clear with psychedelics. I don't know why I have to ask permission.
But Adam, I did my PhD on just a mere 65 questions that you can ask a patient to find out if they empirically have anxiety or not. So I just distrust if you could just talk to me for a minute and tell that I'm incredibly anxious. I don't think that
I could understand why people wouldn't trust that, and that's why the lived experience.
I'm making a joke. I don't have a PhD, and I would never give you 65 questions. I'm making fun of a perspective in the industry that emails me for some reason. There are other podcasts you can listen to.
If you told me that there was 211 questions, I would have been like, yeah, I know exactly what you're talking about.
Yeah. Well, I mean, we want to have these empirical metrics so that we can study things.
We need them.
Yeah.
We need them because the law needs them.
Yeah.
The law wants them. The law wants us to tell people, hey, here, sign this thing first before we talk.
I mean, if you need 8 to 12 sessions to tell if somebody has dissociation, I think there's a serious problem. I mean, I'll admit there's times where I'm like, maybe this person's slightly on the autism spectrum and there's dissociation, or maybe I'm just seeing this. I see the kind of deep awareness of the body while also like a disconnection from it. Like I see that it's kind of in charge, but somebody doesn't know that, or I see like an absence, and it takes a while to figure out exactly what the flavor of that is or what's going on sometimes. But to miss it entirely, I think is...
Well, it's not just a matter of 8 sessions. What that statistic is it takes 8 different, like it took me 5 times to get an accurate diagnosis. That means that could have been with that therapist for years, not just 8 sessions. They could have been with somebody, and I have plenty of clients in their history. They were with somebody, and I was the first one. I mean, finding out that somebody's dissociative, and now granted that other clinicians may have known this, and I don't have their reports, and I don't have like empirical evidence. I mean, this is where like, give me the facts. And that's where, again, I go back to this James Webb telescope of like, the facts are proving that like, this is the same phenomena, no matter the chicken or the egg. You're going to have to start to believe that like evolution would have had an in-between stage. Now, I mean, this is just kind of the philosophical of it too, is I guess, Rudolf Steiner had some credibility in the philosophical world for like saying that there is a transition. There's a fifth form where there is a transitional state. And I think, when we start to look at dissociation as a transitional state, like if somebody's dissociated, I say welcome.
Yeah.
Because if somebody is checking out, that means somebody is checking in. You can't have one without the other.
Mm-hmm.
And you can talk to the absent-minded, and it may look like talking to a catatonic person. I'm not suggesting that we do this, but I'm just saying when somebody kind of goes blank, they kind of look like they're brain spotting, and I kind of just say, is there somebody else here? And like that part gives permission. If whether they be CBT, dominant in their belief structure, or cognitive, that 1 + 1 can only equal 2, then like, yes, I do have a lot of concerns for people who are missing that dissociation as a trans diagnostic. And the bigger picture to me is that like addiction as trans diagnostic should have been obvious for a long time.
Well, but a lot of times, like when I talked to Andres Dwani, he's an urban planner. He was like, the biggest problem in like that community is when somebody doesn't want to. Or he's talking about architecture and contractors. He's like, when somebody doesn't want to know something about a design, they start to pretend that it needs more research, and you just have to say, I'm not researching something that's self-evident. I can sit here and I can watch this happening, and so I'll have things happen where somebody will say, well, what do I do? What about ketamine for this? Another provider. And I'm like, well, I like ketamine for some things, but I don't really like it for dissociative disorders because it's a dissociative drug. And they're like, well, what's the research on that? Who said that? And I'm like, I don't think there is any. I don't really need.
Oh, it's categorically. I mean, it's
like,
categorically
it's a dissociative drug you're using to try and treat a dissociative disorder. You're going to put that person further into dissociation. Like if somebody's got an acute flashbulb re-experiencing of trauma and they're not scoring high for dissociation, maybe. If somebody's got a hopeless, helpless depression with no dissociative element.
Well, I mean, as far as I'm not one to kind of go on scales as to like whether or not like how dissociated somebody is, because it's hard to measure. It's a matter of who is dissociated, who is not there. So in my model, what I look at is like really creating, a meeting area. I created a meeting area screening and assessment that I have like a script that like a guideline that people can use. So in like, things like EMDR, so I'm also an EMDR trainer. And so when we ask a part of self, this is why I would just be cautious about like, this part is saying like, like I'm psychotic and, or everything's fine and I'm not scoring high in dissociation. I really feel like I'm here. Going off of like neurofeedback, I don't know how here you think you are.
Yeah.
Because you're thinking about it. If somebody tells me, yeah, I think I'm here, it's just like, let me know when you know.
Yeah. Well, what about how do you deal with kind of parts of self or parts of the network that are maybe not completely verbal or maybe are more relational, usually very young? Because, I mean, those tend to not have the same access to language a lot of the time.
I mean, how do I access them or how do I communicate with them?
What do you feel like their role is clinically, when it's not a part that can say, I'm not quite here, but you kind of feel the presence of somebody who has, I look at posture a ton. If somebody is like, has more of when I see very strong posture changes and tone changes, sometimes those parts just need to be kind of like encouraged and made room for, but they don't really have a lot to say in language or they don't have access to language.
Right. And I mean, developmentally, there are reasons for that. And that's where we have to be able to switch into age appropriate type of things to help them, move through things and or get access to memories. But so how do I do that? I kind of orient people towards, to me, the reality that I see, and I think it may be more of a spiritual bent, or like somebody could label it as that, but I think it's actually psychologically, sound, in that I have to assume that if you walk in the door, you're bringing everybody with you.
Mm-hmm.
Whether you are aware of it or not. And that's kind of my point, as like when we ask somebody today, 0 to 10, how bad is that memory now? And they give me like a 5. And I say, okay, can you ask the person the age that it happened to? And they tell me a 10. Then I know that they're not on the same page to be able to answer the question. Mm-hmm. And if you have a filter, and this is where the learning disorder type of stuff is getting interesting, because like auditory processing, either it is like a facet of an ear part that can only hear certain like pitches or hear certain language, and it has to go through, and it can't go through. Or if you hear it on this side and you hear things differently than you would on this side, it's all about how the brain receives the messages in those nonverbal type of cues and stuff like that. So like, yes, a lot of posture, a lot of bodily stuff. I don't really talk. I mean, as far as brain spotting, that's where I would go to a lot of my preverbal stuff. To your point earlier about like, EMDR, brain spotting, and like I would use EMDR later on for some more of the cognitions, the behavioral cognitions, but like a lot of my preverbal stuff is very brain spotting based to help the body find its regulation points, but also like test the system to see how it's going to respond to what I would call like adaptive dissociation or mindful dissociation. And that's not it's only an oxymoron if you believe that nothing is nothing. Like that there's, I mean, the absence. I mean, the only thing the black holes are really like the absence that we don't know, but like I'm more than sure that they're connected to something somewhere. If something's eating something, it's going out some other door. So I don't, it just has to, if it's an organism. So, so the other part too is that like what I said to you earlier is that like the youngest parts are the oldest, meaning they held the wisdom. So like I'm 46, so my 6-year-old self is 40 years old. If that math doesn't make sense to you, it's because it's emotional math. It's inverse math in the sense that your 6-year-old has been in the car for the last 40 years.
Yeah.
So when I start talking to the 6-year-old as if they are, equals and or like, I want to learn from you. I understand that you've been here longer. If they're behaving like they are 6 or like have those 6-year-old needs and stuff like that, then we want to structure the system as somewhat like, where's the today you, where's the future you, how can we kind of create that? And so when we're talking temporal space and time, we have to help people be able to create past, present, and future them, because a lot of themselves don't know what's going on and who's what and where. There's black again. It's really a circle.
Yeah.
It's really round. So a spectrum.
What you're saying has so much resonance for ETT. When if you ever get the emotional transformation therapy and look at what those colors do, it's wild, because the far red end where you lose visibility of the red, it's almost like going into the body without you. So it's like experiencing the body without self. Whereas violet, when you start to get violet loses visibility, you're going into higher order thinking without you. So you get very secular or existential or spiritual higher concepts of like thought without yourself. Whereas the other one, and if someone's on an fMRI or a QEEG and they look at far red, you get the same networks that activate with phantom limb syndrome, with body dysmorphia, with dissociation due to sexual assault or some kind of invasive surgery. That stuff does have a more of a neurological basis than, even Watts was aware of.
No doubt. The color thing, I saw something recently about that too. I forget what it was called though, but that's fascinating, because like, how we're going to kind of do this is like, and I don't know, we just have to be able to not question that there is a science. Psychology has a science here. Like qualitative is not nothing, and we know more than what we're doing, and more than what the medical and I would say the law kind of agrees is possible. Like I see healing in miraculous ways, and kind of my point of kind of bringing some of this up is that like you taking I'm not necessarily against taking ketamine as a dissociative to get through, because I think sometimes you have to punch through that. But like I like how you were describing the different ends of that, which would make sense. Code, like, is this how you punch through the other side is the question. But I have very rarely seen like punching through be the answer with EMDR, and like I just trust the brain spotting. I'll just trust the process, and like it works itself out.
You have to know that the brain is going to land. And like what I see when I'm trying to people ask for, I'm not a trainer in brain spotting or anything, but when people at the clinic or local providers are like, can we work through some of these, is what you can teach people is that, I can teach you some kind of tricks that I know, or prompts of you talk enough to get them into the experience, and then you stop because you've got the metaphor right and they're experiencing and the pupil's doing what it's supposed to do, but they need to be let go there. Don't pull them back up in the prefrontal cortex by talking. I can tell a clinician that, but what I see is that if somebody has not done their own work, they don't have faith that that plane will land. And the patient starts to go through it. They start to have distress. And then the clinician puts the stick down because they don't know. I mean, you see things come up, especially with DID, especially with dissociation, where you just have to say, I know that there's healing on the other side of this process, but what you're starting to get is real wild. But if somebody hasn't done that themselves, if they haven't been through it, they don't have faith in holding somebody else going through that process. You know, is that related to what you're saying? I mean, is that too much of a side?
No, I think it's fair, and I think that's why we do dual attunement, within Brainspotting, and it's not necessarily, I mean, we highlight it, but it's not like almost like required in like EMDR type of things. But no, it is. Though the dissociative, so when we look at, to me, the cannabinoid system as a way of helping people kind of regulate their alpha compared to like the pain system with the opioid and the that system, I don't know what dissociation means if somebody checks in, if somebody checks out. Like there kind of always has to be a driver unless they're asleep, but even then you have a driver that is trying to, if they smell the smell of smoke, they're going to wake up.
Yeah.
And it probably can tell the difference between like, smoking, cigarettes versus like fire smoke. Like it is that tuned. And so these youngest parts are often, manifested and honestly, evolutionarily, they're manifesting in like a lot of reptilian type of brain type of stuff, whether that's metaphorical or whether that's actual. I talk to them as if like rings on a tree. All the rings of there are here. Like the past is still here. Right. Each year there's a new ring to you. And my line that I say to clients in my, kind of one of my initial things is like, I know I'm not just talking to you today. I'm talking to every you've ever been. And if you want to kind of get all spiritual or, psychological in a sense or, future oriented, like, and I'm talking to every you will ever be. Yeah. And so like, we're in a different space. We're in the,
it's a timeless part of the brain. Time stops when you're down there. Like if I got somebody into really deep processing back when I was just kind of doing pure brain spotting, if I got somebody into really, especially with one eye closed, the session, they may be processing, if they needed a ton, they may be processing really hard for 40 minutes. And when they stopped, they would think that the session had taken however long it was before that moment. If it was 20 minutes to get them down there, they thought that the session was 20 minutes long, and they didn't believe me, and they were looking at the clock. And I was telling them, man, like that part of the brain does not have a clock. And so you are in this timeless part of experience that
it has a different clock. It still has a clock. It's our circadian rhythms. So van der Kolk gives an example, and the reason why I'll add that to this is because van der Kolk gives an example of a Vietnam vet who goes into a year after gets discharged, and every year the same day, the same time, down to the same minute, he goes into a convenience store, lights up a cigarette, puts his fingers like in his jacket, and tries to hold it up, and then the cops get called, and he says he starts to try to draw fire. This happens, however many times, but every year the same time, down to the same minute. Yeah. So that's the clock. Yeah. That's why people get all thrown off, because of the circadian rhythms being messed up with the daylight savings times. That statistically, you are 10 times more likely, or whatever the statistic is, I think it's a lot more than that, to have some type of medical, because your body gets thrown off, whether or not. Or
just car wrecks. If you want an empirical stat, look at the amount of car wrecks that happen the day after daylight savings time. People are they're not ready to drive yet.
Well, the thing that gets to me about it, and I kind of have a mock campaign on my my YouTube as to like, this is just another example of like, you can't follow the science, but they'll make us follow the science.
Yeah. Well, and the biomedical model, I mean, especially when you do QEEG brain mapping, it's like, even if you accept it based on its own rules, which I think it's always going to be kind of reductive, and we have to have, some kind of framework. You can't completely get rid of something like that. I think it has too much control over clinical work. But even if you accept it on its own terms and you're like, okay, fine, we have to have an empirical whatever. Well, we know with QEEG that if you have ADHD and you respond to the same symptoms, and you take the same medication and respond to, or you have the same symptoms that I can screen for, and you take the same medication and you respond to that, when you get under a QEEG, ADHD is actually 6 different things that could be happening in the brain. And if you're doing that screener, you don't know which one it is. So even if you want to say, okay, fine, biomedical model, let's find these markers and find what's actually going on, oh no, that's too much work. Okay, well, you don't believe in your own thing at that point. You know what I mean? Like you're saying that you have to turn these things into an empirically objective thing that you can see. And now that we can't, the technology is caught up where the clinical wisdom can be validated empirically. They're like, no, never mind.
Exactly.
So,
And
they don't even believe what they're saying. It's just
they don't. So I said when I did that talk with Van der Kolk and his wife, and there's another person there too. I said unconscious informed consent, and Van der Kolk just laughed. Like, because I had said it to him before. We had met twice, and like he was just like, he gave me a look of like, good luck with that. But like I'm saying, I'm like, I have a QEG. I have a QEG. I'm not like. What more empirical do you want? They're never going to believe it because they don't have necessarily access, and that's how how dissociated they may be. And I do take a kind of a stab at like trying to explain this. And one of the there was a Brainspotting article that came out in 2022, I believe, December, that was calling it a pseudoscience. And
some of those papers are really wild, though. Like, there's a guy that published one a year and a half, 2 years ago, and he wrote basically like he was just like, when I was in med school, even somebody in psych, he just was like, I heard about this Brainspotting thing. I mean, it's written in academic language, but he's like, I heard about this Brainspotting thing. That's crazy because when I was in med school in the 80s, we know that memory is in the front of the brain. And eye position wouldn't affect that. So this thing that I have no experience with or training in is not right. And this just goes to show that we should have more better medical training. And it's like where memory is in the brain is one of the most complicated questions in all of modern neuroscience. I mean, that somebody could sit down with a medical license and write that, and that a journal, and I don't want to I don't want to be too specific here, but like a giant mainstream journal would publish it. I mean, that's why I don't want anything to do with research personally. I mean, it's like that.
Well, it's getting even kind of uglier, I think, with psychedelics because the state is actually requiring that people have a license to do research.
Mm-hmm.
That is, and I'm not talking about like they're approving the study.
Yeah.
And right, some of the opening yourself up to what is available within the research community for people to be like, and this is kind of where I'm going from it. And we're not quoting the same article, but at least I don't think we are. But the thing that they're using is APA kind of systematic jargon in my book as to be able to weed out what is pseudoscience and what isn't. And they use this word ophrenia, basically somebody who will papophrenia or something like that. That basically you'll believe whatever I'll tell you. They were calling brain spotters that.
Yeah.
And my only question to that is, do we agree that meditation is evidence-based? Can we have a common, just
or attachment theory?
Or attachment theory, sure. And that developmental trauma exists, in the grander scheme of things. Or to my point would be, okay, so are there other addictions besides, even though eating disorder isn't really labeled as one, but are there other addictions besides alcohol and drugs and, gambling? Are we saying that there's no other addictions out there that are diagnosable? And we do not think that we are a part of a social control. So you quoted some people earlier, I'm sure you probably know Thomas Sazars or something like that. I mean, the medical and how this has in the pharmacological, and then to take away the drug that we actually have a healing system, and we discovered the cannabinoid system in 2012. And its whole purpose is for healing. I think it's our immune system. It's the body that keeps the score. And I'll kind of leave on this point. There's a body that keeps the score and there's a body that knows the score.
Mm-hmm.
And if they are one and the same, then you're kind of there.
Mm-hmm.
and, past, present, and future us, for anybody suffering with dissociation. And, the Wounded Healers is meant to try and help people kind of find their answers for themselves. And if we can help answer any questions, we will. As far as our research, my dissertation is out there for people to read. Dissociated people are like really interested about going down the rabbit hole of things. I would suggest that because it gives a historical kind of context that you'll start to understand that they sold us that it was they sold us it was a non-addictive opiate, but they also sold us that it was an abnormal response to an abnormal event, and it took them 15 years to overturn that. And I don't know if we're still the other models. If we take a look at what laws we're still following, it's from like the 50s.
Yeah.
So like we're still following
and
the
a lot
logic
of that was just an overcorrection from R.D. Laing and Rosenhan and the anti-psychiatry movement sort of doing some things that made the establishment look bad, and they were like, okay, well, we're going to take away all the subjective ability of psychiatrists to do this, and we're just going to give you something and treat cognition like it is a computer. Computer science is emerging now. We're just going to do that. But then they still kept half of the language of psychoanalysis and psychodynamic therapy and a lot of the Jungian and Fritz Perls and experiential stuff. And it's like, even when you look at that language and then what happened after the DSM-3, it's like it doesn't make sense because, you have two systems that are not coming from the same assumptions.
Approval. It starts to make sense when you need lawyer approval, and it makes sense when you need banking approval, and it makes sense when you need insurance approval.
I think that's the only thing, the only places where it makes any sense personally.
I mean, I get trying to mitigate, injury and stuff like that, but my dissertation cautions or highlights that there are 3 addictions that we're missing, and I think that if we were to take an honest, look at the people who took drugs and actually found them to be helpful and healing, aren't the ones who probably sat in the school and just did what they were told.
Yeah.
And that those there's no judgment in, people's life choices, but you become aware of things. And as you get older, and if you're keeping the same kind of tradition going that isn't serving you and is developmentally probably immature, perfectionism, altruism, and ambitious addictions make sense to me, because that would level the playing field between type A's and type B's.
Well, we'll definitely link to all of your work. And is there anything that you want to kind of say to put a head on the, if somebody is saying, well, I treat addiction or I treat dissociation, or I'd like to start to see more of a relationship between these things, any place that they should go, any place they should look at? We're pretty heavily in the Jungian world. But I do think the older depth psychologists, even though they don't tend to be as aware of it or speaking the same language as these new neurologists and new kind of neuro-informed and neuro-experiential therapists, but a lot of times those worlds don't overlap a ton. People aren't really aware that there was a tradition doing the same thing before, 1980, basically.
Well, I would bring back a couple other traditions within that. I mean, I will go back to mysticism and William James, Carl Jung, obviously. The collective unconscious and the historical context that I feel like I kind of bring to the table. I out of the Wounded Healers, I realized that we're missing a profession, and that is of healer. And anybody who is trained in any trauma resolution, where you actually got something from your training where you could go back and take it to the clients, meaning an intervention like EMDR, and people could actually learn or heal in real time type of thing. You quickly realize about how powerful this is, and that you are no longer in a therapist role. Therapy trains you to become a healer. And a healer is somebody who respects the scalpel in that sense, and I think also knows how to journey that too. So people who have gone there and come back. And so the Wounded Healers is now creating the profession of healer based on those lineages, and also self-help, because Bill Wilson was helped by taking a psychedelic.
Yeah.
I think those with lived experience with these drugs, who know how they feel, and not necessarily know what complications could be with something else. I mean, the organic kind of psychedelics, cannabis, mushroom, LSD would be also there because it's in derivative of ergot, mold, ayahuasca, DMT. These things are all organic. the processing of them is where we get the problem, to me.
I mean,
as far as
going back to
potency.
the Salem witch trials, the psychedelics have been causing a problem for certain ways of life. People eating moldy bread was
Right.
a problem.
Right. Yeah, no, I mean, this must have been like huge, but as far as like, the realities of like, some of those things, and people trying to started to pick up on those things. But right, I mean, I think there were people who probably had those, going for them and knew how to get them. And
even the mystery
those
traditions, Eleusinian mysteries and things, a lot of those ritual objects they're finding, orgot spores that are one of the things that tend not to break down over years. You can still test for it.
Right. And so the Wounded Healers Institute is looking to kind of help people create community around supporting people through their dissociative process, and to give some like, opportunities for people to highlight the parts skills, and or like, have a variety of classes and, support systems in place to help people learn and grow within what I've come to understand. And the healing profession, as an opportunity, is to kind of bridge the gap between no and yes. No, we need to have a little bit of maybe in our life, like maybe, but like, is your room clean? Right? Is your house in order before we start going around telling what other people should do? Like, let's scale it down a little bit to like, we're all equal and doing the best we can. All right.
Well, and I think that you have to learn to not hear it and to recognize it for what it is when you get the kind of dismissive, well, you're asking really important questions, and change takes a lot of time, and I'd really just like to continue to make the same mistake, for another 30 years. So I think you're so smart, and I think you're just asking really good questions, and that's good food for thought for me to ignore as I learn to recognize that answer for what it is. If you're hearing that,
right, it's an opportunity. Hit that T-ball. Excellent.
I really appreciate your time. We'll definitely link to your website and your work in the show notes. And good luck to you. I'd like to continue this conversation.
Yeah, same here, Joel. Real pleasure. Take care.
It's what waits underneath the mask, beneath the bruises you stop looking at. The wound is in the story, it's the silence you wrapped around it. Healing doesn't mean fixing, it means unfolding, cracking open what was sealed tight just to make it through. We spend years avoiding the shadow, but the shadow holds the map. It's not the opposite of your light, it's the root of it. The real change begins not when you become someone new, but when you finally stop running from who you've always been. This is the work. This is the wild, dark miracle of coming home to yourself.